Thanks a lot. So I'm going to talk about popliteal artery aneurysm, its natural history, and probably come up with a treatment algorithm. No disclosures relevant to this talk. So its epidemiology, it's not very common, less than 0.1%, and the most common form of peripheral arterial aneurysms are actually popliteal, usually seen in males above the age of 65. Its chance of having it bilateral is close to 50%, and if you find a popliteal artery aneurysm, always look for an abdominal aortic aneurysm. Usually it's atherosclerosis, but you can have other differential diagnoses like, popliteal entrapment or cystic adventitial disease. Now, usually more than half of them do present eventually. Close to 70% of them within 5 years do come up with some symptoms. Most commonly, a lot of clot, embolizes, acute limb ischemia. Sometimes it causes mass effect too. And then finally, rupture is rare, but nevertheless, it can happen. And these are associated with high rates of amputation. Now, when do you repair? If it's symptomatic, yes, you go ahead. Now, if it's asymptomatic, then if the size is greater than 2 centimeters, now this is not very universal, but some people feel that if it's growing pretty aggressively, or if there's a large amount of thrombus occupying more than 50% of the lumen, definitely consider it for repair. So what kinds of repair? There's open repair, which has been time-tested. There's a whole lot of data on it, and what we've found that it is, especially if you get a venous bypass graft, you get decent primary patencies, as high as 75%, when you go all the way to 10 years. The perioperative mortality is the only concerning thing, which is 1 to 2%, which to a cardiologist I feel is a little bit on the higher side. So how about endovascular repair? It was first described by Dr. Marin and team. It's becoming increasingly popular, increasingly used because it's easy to perform, and we've seen that with the CMS inpatient claims. The primary patency and secondary patency rates are improving, and also, unfortunately, one of the big drawbacks with this is there is increased reintervention rates and also increased thrombosis rates within the first year. Now, yes, they have a shorter hospital stay, which is one of the benefits, and then also fewer peri-procedural complications, so therefore it sounds and feels more enticing. So this is kind of not really a head-to-head trial, but just kind of compares the primary patency rates, and as you see, as you head out to 5 years, the stent arm starts to drop off. While if you get a great saphenous vein bypass graft, the patency stays on, and that's important to note here. Now, here's a meta-analysis which they looked to compare endovascular repair versus open repair. This is including symptomatic and asymptomatic patients. There are close to 4,000 patients in the open arm and close to 1,200 in the endovascular arm. And essentially, these were the comparative factors, and obviously, age was different, given that older people, stenting was more preferred. Now, these were the outcome studied, which I'll lay it out in a chart. So when you look at this unity plot, you can see that with regards to wound complications, obviously, stenting was favored. When you look at thrombosis complications, this was more common in the stent group, and therefore favorable in the surgical arm. And you look at the primary patency, as mentioned earlier on, more favorable in the surgical arm. And then all the way to 3 years, very similar results. Secondary patency was not different. And this is an important point to note, because this is what some of the argument is to say, yes, if we can get the stenting technique better, maybe, it can be comparable to the surgical arm. Similarly with 3-year results. Now, when you look at just asymptomatic popliteal artery aneurysms, and when they did the meta-analysis, actually very similar results. So obviously the thrombosis graft occlusion rates was seen more common with the endovascular repair, similarly with reintervention, and the amputation rates, which is important, was not different in both the arms. Now, the length of hospital obviously favored the endovascular, and similarly with the primary patency rate, the 12-month secondary patency rate, as we saw in the previous meta-analysis, was not different. So when they decided to do a decision analysis model to see with regards to cost and reintervention and see what the long-term quality especially, so that's the quality of life years, what they found was, so this graph, the blue one is the surgery, the yellow dotted one is the stent, and this is medical arm. So these two were pretty comparable, even though surgery showed that they had a little more cost savings because there was fewer reinterventions, as you see with stenting. This is the cost effectiveness plot, as you can see up here. The quality is good, but then the stenting had to spend more, while the GSVB, that is basically the bypass graft, using an autologous vein graft, that's important, had more cost effectiveness. But it's important to know that only if you're able to achieve perioperative mortality of less than 6%, then you truly benefit from QALY. So if you have a surgical center with perioperative mortality of greater than 6%, then you got to really think and see whether surgery is the right thing to do. And again, bear in mind, this is only if you have an autologous vein graft. Now, here's a technique which was described by Dr. Tesserik from Lingen. I've borrowed his slides. So what he does is, after you diagnose the popliteal artery aneurysm, you lay down supera close to 1.5 or maybe 15 millimeter into the healthy segment, and then in the popliteal where the aneurysm is, he lines it up and packs it up pretty tight with 2 layers of supera, and then so on, then finally comes up to the healthy segment and finishes up. And so far, so this is how it looks. This is a single layer, and this is a double layer, and really packs it up. And he did a pilot study, and what he also found in this was the collaterals were preserved, which is very, very important. And these were some of his early results. Now, the follow-up has been kind of anywhere from 3 to 55 months, but he's had close to 1 to 2 thrombosis, and primary patencies have been pretty promising. So this is something new, but again, it's not been really tested here in the US. So what's the treatment algorithm? So I understand this is a very, very busy slide. So the way I'm going to summarize this is this. So if you have a younger patient who's going to be really active, and if you manage to get an autologous vein graft, then I would say surgery will be the best way to go. But if this is an older patient with a lot of complications, high risk of wound complications, then obviously I would prefer stenting. And then again, if they cannot have an autologous vein graft, then at that point I think you should have a discussion with, as a team approach, and decide what is the best treatment for this patient. I think with that I want to end. Thank you.